I am Senan Srirangaswamy and this is Tulsi Aya. What is Barrett's esophagus, Tulsi?
Yeah, the Barrett's esophagus is nothing but metaplasia.
Okay.
Normally, your esophagus will be lined by squamous epithelium.
Okay.
If this squamous epithelium is replaced by intestinal epithelium,
okay,
we will call it as Barrett's esophagus. Metaplasia means a normal epithelium will be transformed into another normal epithelium.
Okay.
Oh, that is metaplasia.
Why does this metaplasia have to occur in the first place?
Yeah, actually, usually our esophagus is a food tube.
Okay.
And just a passage, it will transfer the food from mouth to stomach.
Right.
Usually, it doesn't have any much role in digestion. It has some role to conduct food,
okay,
but it doesn't have much role as such stomach.
Yeah.
So, whenever the acid is reaching the esophagus,
yeah,
it has to try to it should try to protect its epithelium.
Right.
Normally, it is lined by squamous epithelium.
Right.
So, it has to adapt some other epithelium to protect its layer. It is trying to protect its epithelium. That's why the metaplasia occurs.
Barrett's esophagus develops as a protective mechanism for the esophagus due to the reflux. It could be gastric, bile, pancreatic juice, but a reflux coming from the stomach. So there are multiple definitions.
Yeah.
So the Americans define it one way, the British define it one way, the Japanese define it one way. To briefly say, the Americans want both histology and endoscopic criteria for Barrett's esophagus, and the Japanese want only the endoscopic and the Britishers want only the histological.
You see the Barrett's esophagus,
yeah,
that means the lower part of esophagus that is replaced by some abnormal epithelium.
Yeah.
You can see three types of epithelium in that thing.
Okay.
From above downwards, if you see, first will be the intestinal epithelium.
Okay.
Next will be the cardiac epithelium.
Yeah.
Below that, cardio-accentic epithelium. After that, gastric-accentic epithelium.
Correct.
Don't take gastric-accentic epithelium as the Barrett's esophagus. It is not a part of Barrett's esophagus. It is a part of stomach.
Yeah. It is the most proximal part.
That is the lower limit of Barrett's esophagus. Intestinal epithelium will have a goblet cells.
Right.
If you see the goblet cells, then only you can tell it as intestinal epithelium.
Okay.
Below cardiac epithelium, you will have cardio-accentic epithelium.
Yeah.
Yeah. What is the difference between these things? Because it will usually have the features of cardiac epithelium and will have the gastric-accentic epithelium also.
Okay.
The gastric-accentic epithelium will have parietal cells. This cardiac epithelium will have mucous cells. This cardio-accentic epithelium will have both these features, parietal and mucous cells. This doesn't carry the risk of developing into malignancy.
Okay.
Intestinal epithelium is significant.
Yeah.
Yeah. According to American guidelines, they are taking it as the future of Barrett's esophagus.
Yeah.
They are not considering any other thing.
All these three, the common thing is mucous cells. Cardiac has only purely mucous cells, and intestinal metaplasia has both goblet along with mucous cells, and oxyntocardiac has mucous cells along with parietal cells.
What is the normal progression of Barrett's esophagus?
So the esophagus dilates and forms rugae. This is one of the first few changes, and one of the final changes of adapting to the acid or the reflux that the esophagus is facing would be visible columnar lined epithelium. So when we talk about visible columnar lined epithelium, we have listed out the three types of epithelium that is pathological that we can. Once the damage is started, it is going to be continuously progressing, but it may have a variable rate. Okay. Endoscopists often mistake it to be part of stomach.
Okay.
So how do you identify histopathologically esophagus different from gastric?
If you see in endoscopy, you cannot differentiate.
Right.
Because it looks like exactly stomach. He is telling if you take biopsy from this area, you can find the submucosal glands that you can find in esophagus. The lower part of esophagus that looks like stomach is not a stomach actually.
Right.
It is the esophageal metaplastic epithelium.
We have three components of lower esophageal sphincter to say it is patent or it is functional. So three components would be the overall length of lower esophageal sphincter, the abdominal length of the lower esophageal sphincter, and the pressure. So what is the minimum pressure that is needed to...
As you told, sir, the minimum pressure that should maintain, that lower esophagus should maintain is 6 mm.
Okay.
If the pressure is below 6 mm, it easily, our acid can easily reach the esophagus.
Okay.
And the abdominal length of esophagus should be maintained is 1 centimeter at least.
That is a bare minimum.
Yeah, bare minimum.
Part of the esophagus is in the abdominal cavity.
Yeah.
So a part of the squamous cell is in the abdominal cavity.
Okay.
So that is what contributes to the abdominal lower esophageal sphincter.
Okay.
Now we know that the stomach starts from where we start noticing gastric oxyntic epithelium.
Okay.
So the abdominal portion of the esophagus should have squamous epithelium. The moment it changes to anything other than squamous cell, we say that it is deficient.
The esophagus is in thoracic cavity, and part of the esophagus, a small part, will be in this abdominal cavity.
Okay. So abdominal lower esophageal sphincter's length should
be maintained.
Right.
If it is reduced, it has a high chance to develop Barrett's.
Okay.
Part of the esophagus is in thoracic cavity, and part of the esophagus.
Dynamic shortening of the abdominal lower esophageal sphincter that happens postprandially. You have some dilatation of the stomach, so a part of the lower esophageal sphincter is deficient. That is up to 1 centimeter. So there is two good things. One is damaged and one is the residual that is functioning properly.
Okay.
So residual should be minimum 10 mm.
Okay.
So if it goes below the 10 mm, anything less than 10 mm, that is more than 25 mm of damage has occurred.
Okay.
Is severe. The length of the abnormal epithelium that is found between the squamous to gastric oxyntic epithelium is the damage. Just talk about the residual or the functional part of abdominal lower esophageal. 35 mm is perfect. Okay. Up to 15 mm loss body can take it. We have 20 to 35 mm compensated, 10 to 20 mm mild, less than 10 it is severe. Now when we, so 70% of the people who don't have GERD, who don't have GERD symptoms fall in the criteria between 20 to 35 mm. And 70% of people who have GERD symptoms fall in the criteria of 10 to 20 mm.
Okay.
That is the amount of LES that is functioning.
Okay.
10 to 20 mm. And severe is seen when you have less than 10 mm.
So we have to prevent this metaplasia to progress into further dysplasia.
Right.
That is our aim. Once we find the metaplastic thing, we need to keep the patient in further follow.
Right.
And we need to see whether the patient is having dysplasia or not. Okay. And we need to avoid all the things that will cause further GERD.
Yes.
To prevent the patient to enter into dysplastic things. Barrett's esophagus, it carries a risk of 30 to 125 fold risk of developing into adenocarcinoma compared to normal population.
Right.
Yeah. If the Barrett's esophagus, you can divide Barrett's esophagus with no dysplasia, low grade dysplasia, and high grade dysplasia.
Right.
If the Barrett's esophagus, if you see the low grade dysplasia thing, the patients will have a 0.5 to 13% increased risk of developing into adenocarcinoma per year.
Right.
If it is a high grade dysplasia, there is a 6 to 7% increased risk of developing into malignancy per year.
And often there is a confusion between low grade, high grade, non-dysplastic, and you need two pathologists to concur on this because of these confusions.
Yes.
And each of them have different surveillance period. Is there any correlation between cancer formation and the length of Barrett's esophagus?
Yeah, sir, that's a good question. Usually we are dividing the Barrett's esophagus according to the length.
Okay.
If the length is more than 3 centimeter, the Barrett's esophagus that you are suspecting, if it is more than 3 centimeter, there are 0.22% increased risk of malignancy.
Okay.
And if it is 1 to 3 centimeter, that length of Barrett's esophagus, there is 0.03% increased risk of malignancy.
Okay.
And if it is less than 1 centimeter, there is 0.01% risk of malignancy. You can tell it as long segment, short segment, ultra short segment.